I'm Professor Caroline Gordon. I work in the Rheumatology Research Group at the University of Birmingham. I've just given a talk about the management of lupus in pregnancy. The most important thing is that this should be planned. We want to have patients with well-controlled disease on appropriate drugs. That means being aware of the guidance issued in the British Society of Rheumatology advice on drugs in use in pregnancy. And we want patients to be aware that there are risks associated with pregnancy. There is a higher risk of problems during a pregnancy in lupus than in other people. The risks can be minimized by having good disease control before they become pregnant so that the drugs don't need to be changed during pregnancy. If the disease is well controlled when they become pregnant and in the preceding 6 months, there's a good chance the disease won't flare during pregnancy and they'll have a successful pregnancy and outcome with the baby. If the disease does flare, there's a higher risk of things going wrong, particularly the placenta may not feed the baby correctly, placental dysfunction occurs, that leads to intrauterine growth restriction and an increased risk of miscarriage or stillbirth, also an increased risk of preeclampsia, which in turn can cause problems in pregnancy, and there may be a need for premature delivery of the baby. And if the baby is born early, obviously the complications may depend on how early that baby is born. So to optimize outcomes in pregnancy, the best thing is to plan it well in advance and to ensure that the mother attends a unit that is used to managing the type of disease that she has. We've certainly shown that women with careful planning do very well now, and that the old advice that if you've had kidney disease in the past, it's a contraindication to pregnancy, is not appropriate unless they have severe renal failure.